Welcome to the Social Worker's Corner, the place where your favorite social work student gets to break down information you should know about. Why? It's simple, because it matters. Episode 1: The Opioid Crisis in the United States. Thank you so much for joining me. Before we start, let me introduce myself. My name is Maria Barahona, pronouns she, her, hers, and I'm a social work grad student at the University of Texas at Arlington with a concentration in healthcare. Let's dive a little bit into why I chose to talk about the opioid crisis for my first episode. Well, on February 14 of this year, I came across an article published by the Associated Press titled, "Doctors Who Say No to Opioid Use Face Threats from Patients." So this article basically just talks about how one patient threatened to shoot Dr. Terry Hunt if physical therapy didn't work for him. And he also shares a couple of other stories of how his staff has been harassed by patients that have been looking for him. And these are patients that have been prescribed painkillers in the past. So this was one of those situations when once you click on one article, the database starts creating a search based on those. So more articles related to the opioid crisis from 2020, 2021 started popping up for me. So I came across another one from the USA Today, which was published a day after this article, so February 15. And it's titled, "While ER visits were down last year, drug overdoses increased during pandemic." So this article just goes on how a study that was created by the CDC says that there have been more than 180 million ER visits from 2018 to 2020. And it found that weekly counts of all drug overdoses were up to 45% higher in 2020 than in 2019. And this was published February 3rd of this year in the peer-reviewed Journal of the American Medical Association of Psychiatry. And they came across that the opioid overdoses had increased for about 29% compared to the numbers before the pandemic. Then you tell me, shouldn't we talk more about this? Why aren't we breaking down more the information for people to understand, hey, this is important. This is something that you need to worry about because it may affect someone you love or someone that's very close to you. So that's what I'm going to try to do today. I'm going to try and break down the information for you. I'm going to share with you what are opioids, what are the most common, how the DEA classifies them, why people misuse these types of medications. So let's dive in. So what are opioids? Opioids are drugs that are given to relieve pain, and they're often called or referred as painkillers. They naturally are found in the opium poppy plant. So if you don't have anything to do after we're done with this podcast, Google an opium poppy plant. It's so beautiful. How do they work? And I'm not going to get into the pharmacokinetics of this because the pharmacokinetics and the mechanism of action of how these types of medication work are very complicated but simple. They just block pain signals between the brain and the body. What are some of the most common? You've probably heard of Vicodin, fentanyl, morphine, Percocet, and Demerol. And the list goes on. And if you've ever watched House MD, you can relate, right, to the situation of Dr. Gregory House, who is a very brilliant physician who is struggling, right, with Vicodin. The NSDUH, which is the National Survey on Drug Use and Health, they collect information on the reasons people misuse prescription psychotherapeutic drugs. And they define the misuse of prescription drugs as taking drugs in a way the doctor did not direct the respondent to use them. And they may include using without a prescription of the respondent's own, using in greater amounts more often or longer than the respondent was told to take them, or using in any other way a doctor did not direct the respondent to use them. The NSDUH also asks the participants on why they misuse a prescription pain reliever. And the responses were the following: to relieve physical pain, to relax or relieve tension, to experiment or see what the drug is like, to feel good or get high, to help with sleep, to help with feelings or emotions, to increase or decrease the effects of other drugs, or also because they're hooked or has to have the drug, or for some other reason. And let me just state this before we move on. Addiction is a disease. Like any other disease you may know of, addiction is a disease. So what is the historical background on opioids in the United States? So basically, the US has seen it in three distinct waves. The first one happened in the 1990s, which involved prescription opioids, natural and semi-synthetic, and methadone. In 2010, when they saw a rapid increase in heroin overdoses, and in 2013, the significant increase in overdose deaths by synthetic opioids, and that most of them were illicitly manufactured, like fentanyl. So now we're going to talk about why does this matter? Why having this conversation about the opioid crisis matters. And all of the references to the information that I'm breaking down to you guys are going to be towards the end of the video. I'm going to be showing a couple of graphs through the podcast in order for you guys to see the numbers that I'm talking about. So the vast majority of people who misused opioids in the past year, they also misused prescription pain relievers. 9.7 million people aged 12 or older misused prescription pain relievers in the past year, compared with 745,000 people who have used heroin. So we're talking about people that are 12 or older, and 9.7 million people, that's a lot. Now moving on to 2019, the majority of the 9.3 million misusers of prescription pain relievers had misused only one prescription of pain relievers in the past, but they had not used heroin. And if, in case you didn't know, people that have been using or misusing pain relievers for a long time, or opioids, and when they're caught from not receiving that medication anymore, a lot of them tend to go towards heroin, a street drug which has the same effects as pain relievers. Moving on. The overall national opioid dispensing rate has declined from 2012 to 2019, and in 2019 the dispensing rate had fallen to the lowest in the 14 years, for which we have a data of 46.7 prescriptions per 100 persons. A total of more than 153 million opioid prescriptions. So by this they mean the amount of prescriptions that have been given by physicians throughout the states. In 2019, an estimated of 404,000 people had misused prescription pain relievers and used heroin in the past year. So that's a lot. 404,000 people that have misused pain relievers and also used heroin. 341,000 people had used heroin in the past year but had not misused prescription pain relievers. So if we compare that with the 4.2% of prescription pain relievers misusers who also used heroin in the past year, 54.2% of heroin users also misused pain relievers in the past. So it's very hard. So we have people that are struggling with misusing a prescription, a drug. Then we have another group of people that are dealing with, having a substance use disorder with heroin. And then we have people who meet in the middle who have been misusing both. So don't we have a problem in there? I know that things have been getting a little bit better with time, but we still need to work on it in order to lower those numbers. Because come on, just look at the numbers. 404,000. That could be the population of one country. And it's crazy. I mean, it's just think about it. Compare that number to the population of one small country. Like, that would tell you, just think about it. Like, everyone in that country would be misusing prescription drugs and could also be dealing with substance use disorders. So more than 760,000 people have died since 1999 from a drug overdose. 2 out of 3 drug overdoses deaths in 2018 have involved an opioid. And this information is from the CDC. So we can rely on what the CDC says. Approximately 10.1 million people aged 12 or older misused opioids in 2019. Let me repeat that again. 10.1 million people aged 12 or older misused opioids in 2019. And then this information is from SAMHSA. As many as 1 in 4 people who receive prescription opioids long-term for non-cancer pain in primary care settings struggle with addiction. So we're seeing that this comes also in the format of, pain relievers are given to patients that are already struggling with very hard diagnoses like cancer. But it's just how this particular drug works in the body that allows people to become addicted to it. In 2019, again, dispensing rates continue to remain very high in certain areas across the country. 5% of U.S. counties, enough opioid prescriptions were dispensed for every person to have one. Just think about it. 5 U.S. counties, like, I'm not going to go into which counties are they, but dispensing enough prescriptions of opioids just to think about, oh, my neighbor to the left has opioids, my neighbor to the right has opioids. So it's just crazy. Like, a lot of these places, I mean, it's been getting better with time, but opioids are not candies or chocolates you can pass out. While the overall opioid dispensing rate in 2019 was 46.7 prescriptions per 100 people, some counties had rates that were 6 times higher than that. 6 times higher than that. So let's talk a little, those were the negatives, the bad things, the numbers. Let's talk about a little bit of the positives. And by positives, I mean, what are the good things that involve policy? What have we done to make this situation better? So one of them is MAT. So MAT stands for Medication Assisted Treatment. And this is used to treat substance use disorders as well as sustain recovery and prevent overdose. It's a combination of medications, counseling, and behavioral therapies. So we're talking about 3 different paths a person takes, right? in recovery. MAT is primarily used for the treatment of addiction to opioids, such as heroin and prescription pain relievers that contain opiates, as we have been mentioning. The prescribed medication operates to normalize the brain chemistry, block the euphoric effects of alcohol and opioids. It also relieves the physiological cravings, and it normalizes the body functions without the negative and euphoric effects of the substance use. So MAT, the design of MAT is a good thing. We also have now things like drug courts, which you may be wondering, what are drug courts? So they basically help participants recover from use disorder with the aim of reducing future criminal activity. It's an alternative to incarceration. To reduce the burden and cost of repeatedly processing low-level, again, let me repeat that, processing low-level, non-violent offenders through the nation's courts, jails, and prisons, while providing offenders an opportunity to receive treatment and education. They're still held accountable for their behavior, and they have to fulfill their legal responsibilities of the offenses they have committed. So it's not like, oh my goodness, like they've committed a crime and they're going to be set free. No. I mean, they're still held accountable for their behavioral situations, and they have to comply with their legal responsibilities. But they're also, provided with treatment and education. So it's there's something, again, that exists that's a combination between a drug court and a MAT. And as we said already, MAT is the medication-assisted treatment. And we also have now things that are called family treatment drug courts. So these are alternatively, I struggle with certain words. They're alternatively known as dependency drug courts or family drug courts. And they use a multidisciplinary collaborative approach to serve families who require substance use disorder treatment and who are involved with the child welfare system. And if you have no experience with a multidisciplinary collaborative approach, by this they mean, involving a social worker, involving a physician, involving a psychologist, involving a physical therapy, whatever they need. So yeah, that's a multidisciplinary collaborative approach. And in this case, it's also dealing, with the welfare system and with the judicial system. And all of this information that I've been talking about comes from SAMHSA, which is the Substance Abuse and Mental Health Services Administration. So what about policy, you may ask? Here's the tricky part in this whole situation. Policy. Social work itself is very political. It's a very political profession. Our profession works according to what policymakers are doing, and we work based on what the person that's in office, right, is doing. So far we have state laws on prescription drug misuse and abuse. We have a total of only 8 laws right now that deal with this drug misuse and abuse. And state laws itself are often used to prevent various injuries with demonstrated benefits, yet little information exists about the effectiveness of state statutes or regulations designed to prevent prescription drug abuse and diversion. Here's the caveat, though. States have the primary responsibility to regulate and enforce prescription drug practices. And if you remember anything from your U.S. political class or U.S. politics, whatever you want to call it, the federal and state governments work differently. A law may be adopted by the state once it has been enacted at a federal level, and it's up to the state whether they wanna enact that law exactly as the federal level states it. or if they want to regulate or modify that law. So in this case, again, this applies to state laws. The state is responsible to regulate or enforce those prescription drug practices. There is one called doctor shopping, which is referred to a patient obtaining controlled substances from multiple healthcare providers without them knowing about the multiple existing prescriptions. We have a prescription drug time and dosage limit laws. Many states have enacted laws that set time to control substances. We also have a tamper-resistant prescription form requirements, which are an attempt to prevent fraudulent prescriptions for controlled substances. We have a state prescription drug identification laws. So basically only 25 states out of 50 have laws either mandating or allowing pharmacists to request IDs before dispensing prescription drugs. Let that sink in again. Only 25 states out of 50. We have laws pertaining pain management clinic regulations, which they prevent inappropriate prescribing. Regulation of pain management clinics, often called pill mills, when they are sources of large quantities of prescriptions. People tend to go to pain clinics, to get the pain relievers. So that's why they call them pill mills, and they're regulating them. And we also have prescription drug physical examination requirements. If they require a licensed practitioner to examine the patient before prescribing a medication. By practitioner, they refer to a physician, a dentist, a pharmacist, a physician assistant, nurse practitioner, or any other person licensed, registered, or permitted to prescribe, dispense, distribute, or administer a controlled substance. Again, these are your state laws. So in conclusion, what can you do? If you are a social worker and if you're passionate about this particular topic or working with this particular population, you can advocate for policy changes. If you're a social worker that works at a policy level, advocate for policy changes. And always update yourself in the newest information regarding opioids if you're working in that setting, right? And if you're, again, passionate about this population. As a society, what can we do? Let me emphasize this very much. Vote, vote, vote. And I don't mean this as being blue or red or whatever, green, purple, no. I mean this just vote. Vote at a local level and a national level. Keep in mind, please, that policies affect us whether it is good or bad. We need more resources at a correctional, community-based, and behavioral health settings. We need to increase screening and assessing for opioid addiction. This has to be stronger, not only in a healthcare setting, but also in a community-based behavioral health setting, as I mentioned, or a correctional setting. We have to ensure more access to treatment, making sure that insurances, right? This may be a policy change. I know that Medicare does some with it already, but we have to make sure that private insurances include MAT, right? Which is a medication-assisted treatment and counseling for opioid addiction or just substance abuse in general. And this is also ensuring that people have healthcare coverage immediately, right? As there is a recognized addiction, we can reduce the gaps in access to addiction treatment and also reducing the risk of people relapsing. We can also increase recovery support services such as housing and other supports in the community. I mean, there's a broad range of programs that exist already, but these programs exist as long as there is funding for them. So we need to make sure that there is funding for community-based programs that can help people access, right? Those things as employment, education, and housing, because a lot of the times you have to keep in mind that people tend to go to substance abuse because there's multiple things, multiple factors that are influencing their lives at that moment. And most importantly, we also have to keep in mind that we have to invest in research development of safe and effective medications. Opioids are a problem because whether a person is already addicted, a person may develop that addiction just if they are a cancer patient, because that's just the effect that drug has on the chemical balance of the brain. And we also have to advance practices in pain management. And the only way of doing this is promoting policy change, and through policy change, we gain funding. It is important. Keep in mind, please, that this may affect someone that you love, someone that's very close to you, or yourself. So, thank you so much for joining me for episode 1, and I'll see you guys soon.